morning and welcome. Thanks for coming out. I wanted to welcome you all to New Orleans and the Academy. This is our hometown, and we're really excited that the Academy's back here after 20 years, and we hope you all are enjoying it. And I'm glad we could arrange some cool weather for you. So today our topic is advanced airway management, the anesthesia otolaryngology team approach to the difficult airway. And sitting next to me is Skylar Haley, who is lead CRNA on our airway management team. Missing is Murray Stokan, who is Dr. Palm's anesthesia lead. Unfortunately, he didn't get a chance to make it up from down under with us. Dr. Palm, who is the head of the head and neck program at the Chris O'Brien Lifehouse in Sydney, Australia. He's a head and neck cancer surgeon who also does difficult airway work, and I'm Andy McWhorter, so at LSU here in New Orleans, so welcome. It's an informal session. Please feel free to interrupt us and ask any questions you may have. So without further ado, we have no disclosures. We're going to go through Thrive. Carson's been working with it for a few years. I know a lot of people that's the reason why they're here, to see about that. Talk about airway management in general, especially jet airway. It's a key part of our practice. And also, as we're both laser cancer surgeons, we have a real interest in preventing laser fire as well. So go through some techniques and tips and how to do this. So why are we talking about this? Well, if you look at the anesthesia literature, airway management and difficult intubation is the highest rate of difficulty the anesthesia has. Not cardiac issues, not anything else. It is very prevalent, okay? And as otolaryngologists, we know there are a lot of places where we can get into trouble. Whether you're a general practice or a head and neck surgeon, lots of levels of opportunity for badness to give our patients difficulty. So maybe the most important point in this is preparation and good pre-op evaluation. Knowing what you're getting into ahead of time is obviously the most important. But an airway team, we were just talking before the meeting about the difficulties with anesthesia when you're not familiar or who's going to be in charge. And having someone that you work closely with or a group of people is indispensable in terms of having confidence in each other, knowing your skill sets, being complementary, being able to communicate effectively. That's it, and that's all part of having an airway plan. And again, indispensable in having success. When we get in trouble is when we don't have options and we don't know what we're going to do. You're the captain of the ship. Check your instruments and your equipment. You never know. You have a new scrub, something's not working, that light source doesn't work, the flexible bronch isn't plugged in, or it's got water damage on it. Have all your tools available, and equally the same with anesthesia. So check all your things yourself. So in the airway evaluation, there's key decisions that are going to set you up for success or set you up for failure. And so is this an emergent situation or is this an urgent situation? Last week, one of my partners was talking about being on call and being called to the emergency room. The ER doesn't always do the best job of calling us, and assessing this patient and where they were going to best manage that airway was having the confidence to know how the patient was doing, being able to confidently evaluate the airway. Do you have time to go to the operating room and do this with all, in the most controlled fashion, or was this someone who's going to need to be intubated in the emergency room? The importance of Sterter versus Stridor, upper airway obstruction versus a fixed obstruction, commonly confused, just like it's not uncommon for us to all see patients who've been treated for asthma who end up having airway stenosis. We listen, it happens all the time. Had someone tell me, yeah, the guy'd been treated for asthma for a year. They walked in the office and he said, that's Stridor, and looks down. Of course, they've got a subglottic stenosis. How everybody's heard that story. Also, our ability to adapt, right? In terms of as you're looking at this patient and have a conversation, is this acute or is this chronic? In the angioedema patient, the airway is going downhill very rapidly and they have no time for compensation. That's a very, very dangerous airway. The guy with obstructing laryngeal cancer who's had Stridor for a month, I'm not saying he's not critical, but he's been slowly getting worse, holding on to his airway, and it's not necessarily the acuteness that you may have in that time frame.
Yeah, I think this is really, really important, and I think this really demonstrates that the ENT surgeon is really the custodian of the upper airway. You know, we are the people that understand the anatomy, we are the people that understand the physiology, and it is really important that we understand how to assess these patients. And one of the absolute caveats is to understand that the diagnosis of upper airway obstruction is a clinical diagnosis. There is no blood test, there is no saturation monitoring, there is no imaging. It is a clinical diagnosis. We are the only ones that understand the concept of stridor and the difference between stertor, you know, stridor being the turbulent airflow of a narrowed airway, and we understand that the diagnosis is made by looking at the patient. What's their respiratory rate? Are they autonomically disturbed? Are they sweating? Are they tachycardic? Do they have inspiratory muscle recession? Do they have a tracheal tug? You know, these are all the signs and symptoms of upper airway obstruction. SATS monitoring will be showing the patient saturating at 97%. If there's one thing that annoys me most is when a resident rings me and tells me this person's got an airway problem, but gee, the SATs are 97%. Because what happens to the SATs when they drop? You've missed the boat, the person's about to arrest. So saturation monitoring is of no value. CT imaging is of no value. It's a clinical diagnosis. And in terms of the time frame, absolutely. The patient might have had this for 10 years, walking with inspiratory stridor. That's a chronic situation, and that's going to lend some comfort to how you're going to manage that person. They might have an acute episode where this started about a week ago, and the difference is between whether this is acute progressive, acute non-progressive, chronic non-progressive, or chronic progressive, meaning, and each of these different situations require timely intervention. But I think the important thing is it's a clinical diagnosis.
Absolutely. Thank you, Carson. And in your evaluation, ease of access, what does this patient look like? What are the comorbidities associated with them? Is this a frail hypertensive who's had an ACDF, who can't extend their head? What else is going on? How well can you see this airway? Do you need imaging if it's not making sense? If the patient's symptomatic, you may say this compression of the trachea here. Do we think they're intubatable? Yesterday I went home and operated, and we had a lady who has probably a plasmacytoma that's infiltrating through her larynx, and she had significant infiltrative changes throughout the supraglottis, and you couldn't see her airway. She had mild stridor arrest. You know, are you going to fiber optically intubate this patient, or is she maskable? And making those decisions. How are we going to get there? What are the other things? How well could she open her mouth? Making all those decisions. And it's about that personal assessment, like Carson's alluding to, of the airway. And your exam, right, emphasize your flexible laryngoscopy. If for those of you in training, you know, we all have great resonance, but if you're dealing with a difficult airway, it's nothing like you having eyes on that situation so that you know exactly what's going on to be prepared. Plan with multiple layers of redundancy so that you have backups, and communicate that plan. And to the timeliness of, come on, computer.
So just to point what I said before, that CT scans my patient. This is a person who walked into the office with obvious stridor, who'd been like that for 10 years, right? And misdiagnosed for asthma. So that is a chronic airway obstruction from a goiter. All right, so that is a safe situation. Not a perfect situation, because you're going to have to, you know, give this guy a better breathing tube, but he's been walking around like that for years. So it's that context that's really important, how you're going to manage it.
Right, and same here, listening to this voice. We should. Well, we'll play it here. Are we not going to get sound?
Is there a sound from there?
Yeah, it's not giving it to me. All right.
Can you play it through the speaker of the user? Is there a sound turned on?
Well, we checked it, but it didn't check sound. Sorry, guys. Essentially what you heard was stridor in this guy with bilateral vocal cord paralysis, but to Carson's point, he's got a terrible airway, right? He's got a 2 millimeter glottic chink, but he's been walking around like this for years. And just knowing that patient and seeing what's going on, but it's pretty impressive. When we get to this airway evaluation, so you may not want to bronch this patient. You may not be in a setting where you can. If you're using a scope that's a chip at tip, a nice, quick, easy hack to see the airway. These are the same airways, and if you look on the left here, we're looking at normal light. What we've done here is we have turned it from auto to manual and had them tuck their chin to their chest, and you can see the obstruction in the airway without anesthetizing the airway, without having to go below the vocal cord. So just a chin chuck in full light where the computer's not feeding back to yourself, okay? I'm gonna let Skylar take over and talk to us a little bit about anesthesia's assessment.
So pre-op assessment is one of the most important things that we can do to predict difficult ventilation, difficult exposure, intubation. First thing you evaluate, 50% of our population is going to be a 4 or better on the stop bang. So everybody in South Louisiana has sleep apnea. And no matter the first part are all the subjective or has anyone seen you snore while I sleep by myself? But the last part, male, gender, over 50, hypertension, BMI over 35, bells should go off immediately on that one. It's not going to be straightforward, lots of redundant pharyngeal tissue on exposure. Airway assessment, the normal range of motion, Mallampati assessment, thyromental distance, ability to prognathe the mandible. All these should be done, and this can be done within 2 minutes, this entire assessment. And you say, okay, well, look, let's get ready for a rodeo. You get ready to spin and DL if we can't get the tube in. So having your laryngologist there on induction is highly recommended for these cases. Head elevated laryngoscopy position, again with the BMI. When you lay them flat, everything's in your space. So just simply sitting the head of the bed up 30 degrees if you can, dropping it down a little bit so that you can see everything. Even getting a stool if you need to really increases the FRC in the morbidly obese, prolonging your oxygenation time. A mandibular tori, these go unrecognized all the time until after. I don't know why, he doesn't have any predictors, but I can't expose. The calcium formations growing on the mandible, often associated with torus palatinus and the palate as well. So a simple lift your tongue to the roof of your mouth and evaluate whether or not they're there. They're genetic. They grow over time. The older they are, the bigger they get. We've had a few patients that we've actually had to send to get them cut out just so that we can expose them. But it's a simple assessment, and unfortunately it goes missed all the time, unrecognized, until we get into a situation where we can't expose the patient, and we look and they're humongous bone and we can't manipulate the tissue. And of course, like we said, if any or most of these predictors are there, it's always advisable to have backup, have your laryngologist there with multiple different plans of managing the airway.
Right. And so, it's not just about our assessment, it's the whole team's assessment. Skylar and I work together and the rest of the Airway team, but we look at different things about the patient too. And so having everybody on the same page and then discussing that. That's the idea about this pre-op plan. It's been shown to work with pilots. We now have a surgical safety checklist, which is the big buzz. In sports, we have our plan ahead of time, and here's Skylar and one of our scrubs. And we have the luxury of being able to look at all these videos that are coming from the office ahead of time at the operating room, which is an indispensable tool if you can do that, so that everybody is looking at that. So when we do all of our critical airways, we have video recording, and the scrub knows, the anesthesia team knows, the surgeons know exactly what we're going to be looking at when we get there in the elective situation. So a big part of this, right? Look, we all drive scopes. Driving a flexible scope past a lot of this is no big deal. We all work with direct laryngoscopy and having the right tools to do that. That's not the hard part for us. That's what we all do. But working as a team, and I'll tell you that nothing is more important to me in managing the airway than having good anesthesia, because they may be a good anesthesiologist, but providing good anesthesia in airway situations are not one and the same. And having someone who's experienced, not only that you can communicate with, but understands what you're doing, makes all the difference in the world. And so I'm going to let Skylar roll again with that.
So one of the biggest things that everyone is scared of is paralysis. More often than not, if we're having a hard time ventilating a patient, it's because they're fighting. Not all of our patients can tolerate the amount of anesthesia it would take to actually get them deep enough to tolerate being manually ventilated for hemodynamically. Everybody's older, on multiple antihypertensives, multiple comorbidities. So early paralysis often resolves any issues with mask ventilation. Opening the airway with an oral airway, patient's not fighting, they can tolerate enough anesthesia to just not remember, but not necessarily enough to put them all the way down. And then early paralysis oftentimes improves ventilation significantly. In the absence of multiple other predictors of, oh, this patient's going to be difficult to ventilate and difficult to expose, and they have a ball valving mask. Okay, sure, we're not going to just early paralyze those patients, but most of our airway stenosis patients, if they're fighting at all, we're not going to move air. We're going to put everything in the esophagus. So early relaxation helps a lot. And then, of course, through laryngoscopy, through the entire case, if you don't maintain good, dense paralysis, that's when you can have some problems. We have, unfortunately, some patients a long time ago, people are scared to paralyze, they barely give anything, and hemodynamically not doing so well, so you lighten up the anesthesia, and then they start coughing, bucking in suspension. And we've had a torn vocal cord, and not us, that was before my time. But anyway, especially with the advent of Sugammadex, acroleonium and vecuronium, low side effect profile.
I got that right here for you.
Sugammadex reverses both of those within minutes. Traditionally, neostigmine has been used to antagonize. That's not a true reversal of the paralysis. Neostigmine and glycopyrrolate together have a very large side effect profile in comparison to Sugammadex, and they can take 10 to 15 minutes to peak, whereas Sugammadex can reverse the paralysis within 2 minutes, fully reversed. And because it works so well, oftentimes we wait until our patient is almost awake enough to follow commands and be ready before reversing, because we get into the same situation as when we went to sleep. We go to sleep, paralyze them, it's easy to ventilate because they're paralyzed. You unparalyze them too early before they're awake enough to follow commands and breathe on their own, they start fighting you again at the end of the case. In which case, succinylcholine is a good option in that time. You couldn't go with another non-depolarizer like Rockerbeck because the Sugammadex is so effective. So doses as small as 0.5 milligram per kilogram of succinylcholine up to 20 milligrams, which is 1 cc of Sux, will relax the cords enough to get you through that laryngospasm and continue waking the patient up until they can breathe on their own again.
And Carson wants me to come, but this is a game changer for you. You know what I mean? None of our patients cough waking up. None of them fight. They're not waiting to wake up, chewing on the tube, you know, all that stuff that you have to live through. That's all garbage, right? That's dangerous. That's putting a patient in an inappropriate level of anesthesia for what's going on. And so modern, better living through pharmacy with someone who knows what they're doing. Carson?
Yeah, look, I would totally agree. I mean, I think one of the teachings was that you should never paralyze a patient unless you know you can ventilate them, you know, certainly by hand. And our practice is very similar. But the basic principle is, you know, anesthesia is instituted, it depends, one of the big things about managing an acute airway problem is if the patient can lie flat. And you can actually assess that sort of clinically, because if a patient can't lie flat before you start anesthesia, that can be a major issue. But, if you have a patient with a marginal airway, it's not great, but they can lie flat, the way really to institute anesthesia is one of two ways, either via inhalational techniques or propofol. And then once you get the patient deep enough, you can ventilate the patient with the mask. And if you can do that, the patient is entirely safe to paralyze. And that's one of the real simple sort of tests. And the other key point is that once you've achieved a deep enough anesthesia is you've got to topicalize the vocal folds with topical anesthesia, because, you can undo all the great work when the patient kind of wakes up and has laryngospasm. So I think that's really important. One of the major game changers has been the advent of Thrive, and you'll talk a little bit about that later on.
And what Carson's alluding to, and Skylar's going to talk to us about masking in a minute, is one of the things that I see when we're called to emergencies is when we're working down a critical airway path, and we arrive on the scene and they're like, we can't intubate the patient, right? The patient's gone from a semi-stable situation where they were protecting their airway and they've made it an unstable situation. And so as they're working through the algorithm in an emergency response to the airway, they've been masking the patient and they were holding their own but not doing well, so they decide they're going to intubate the patient, and then they can't intubate the patient. And then it hits the fan, right? And what are we going to do? And you've got the ER doctor with the knife in their hand, which there's nothing scarier in the world than that. And they're calling you and you're coming rushing through the hospital to get there. But never forget that you can go backwards. You mask the patient before, you can mask the patient. There are many airways that you can mask that you can't intubate. And never forget to go backwards. And it's kind of a counterintuitive step sometimes if you're not thinking about it in the heat of the moment where you're trying to get the tube in and they're calling you for the emergency airway, and you just take to the side and you get the mask on and you start masking again, and you take an out of control situation back and get everybody to catch their breath, and let's make a decision of how we're going to go forward.
I mean, Andy raises a really good point, which goes back to the most important part of this talk, which is at the beginning of the slide. You've got to work as a team. And, Andy describes a situation where there is no team, where you're coming to a situation that's uncontrolled. We're talking about situations where we work together all the time. So that's why it's fluid. It all works quite straightforward. I think that scenario is actually one that you don't really have a lot of control of.
Very true.
And it can be an incredibly frightening situation to deal with.
So mask ventilating, very important, especially in a fixed airway stenosis. You're not going to move air faster than it's going to go through that small airway. And the harder you go and the faster you go, the more you're going to ventilate the esophagus. And then you get into a whole nother world of trouble there. So prolonging your inspiratory time and having a long inspiratory time at low pressures will give you the most efficient ventilation, avoiding high peak pressures. So a nice slow ventilatory rate at a peak pressure that's safe to avoid esophageal insufflation is paramount.
And it's amazing how poorly understood that phenomenon is. Skylar teaches all these people anesthesia. Got all the students coming in all the time, and they're not moving air well in these situations. Slowing it, if you're dealing with narrowing, you can't get the air in fast, right? It's going to go to the area of least resistance. It's going to go in the esophagus, versus he just slows down, nice and easy and slow, a long, slow breath, getting that air in. And it's obvious, but it's counterintuitive when you feel like you're not ventilating the patient, right? You want to go faster, you want to get that air in there, you're worried about the patient, and they slow it down and get it done.
As far as anesthesia technique, the ideal anesthetic is anything that works quickly and stops working quickly. So what we use most of the time would either be a total IV anesthetic, and when we do a general endotracheal anesthetic with gas, we use the shortest acting, least soluble gas we have for rapid emergence. So the IV anesthetic is dependent on metabolism and liver function and hemodynamics rather than breathing. So in order to get the gas off, you have to breathe, whereas if you're having a little bit of an issue, as long as they still have blood flow to their liver, they're going to wake up. So we employ a TIVA a lot, especially when we can't put a tube in or where there's going to be periods of apnea where we're removing a tube. If ventilation becomes difficult at the end of the case, the only thing that could prolong the TIVA or the propofol emergence is acidosis. Anything that is a sedative hypnotic and works well to put you to sleep works better when you're acidotic, so you need less of it. So it could prolong your emergence in the event that you're having a hard time preventing hypercarbia towards the end of the case. Generally, propofol or remifentanil combination is fantastic TIVA. It's on quick, off quick, 8 to 10 minutes. Women usually wake up faster than men. But prolonged, and hopefully we don't do this too often, but cases over 6 hours or total anesthesia context sensitive half time of propofol goes up significantly, and it can take over an hour before the propofol is completely metabolized to wake up. So that's something to consider if you're wanting to do total IV anesthesia for a case that's going to take a long time. Switching back over to inhalational anesthetic towards the end of that case will provide for more rapid emergence and quicker turnover time, which is everyone's interest. So in long cases, that's how we recommend doing that.
Right. And like Karsten said, that we established this mask ventilation through an IV induction. And it's so fun to work with Skylar. He'll tell the students, okay, the patient's going to wake up in 6 minutes, and like clockwork, it's like that. I know that's how your anesthesia is at home, right? My chairman's over here, and he's like, why is he not in my room? Oxygen management, Skylar, sorry.
Yeah, so anything you can do to slow down the body's uptake of oxygen, keep them nice and relaxed. I like to use selective beta-1 blockers. They keep the heart rate low, which is going to improve your residual oxygen content, your hemoglobin. In the cases where you may have a little respiratory acidosis because you're doing apneic technique, the oxygen association curves shifts to the right in acidosis, so it actually improves tissue oxygenation. So I don't advocate for hypercarbia, but when it happens, it's not as bad as you think, to an extent. Ventilator management is very important to prevent atelectasis. We have these very high-risk patients that come in. They're at risk for post-op respiratory complications just because of why they're here. PEEP is one of the most important things you can do. 5 on kids, 10 on adults on the ventilator. With all the lung protective measures that everybody's employing, basically treat everyone like they have ARDS. I don't think it's a great idea, especially in our patient population. But anything that we can do to prevent atelectasis is going to improve patient recovery, at least in the acute post-op period. Again, with the slow ventilatory rate, changing your IE ratio. Everybody thinks 1 to 3, you need longer time for gas exchange, but if you don't have a hard time controlling your CO2, the IE is not going to do anything except increase your peak pressures, which can lead to barotrauma. So anything that you can do to decrease your pressures, increase your volume, and maintain normal carbia should be done for these cases.
Yeah. And we do all of this type of work through these tiny endotracheal tubes, right? Which goes into effect of how Skylar manages all this. I know that Karsten likes to use a 4.5, Karsten. Yeah, and we use a 5.5. And everybody's like, that is a straw. You can't ventilate that 250-pound guy that way. Oh yes, you can. Just fine.
I think the key thing is that it is possible. The problem is you can't do it for long. So I think the key is that for short procedures, it's a very simple thing to use.
Ways to prevent post-op respiratory complications on anyone, much less our patient population. Of course, anesthetizing the larynx with lidocaine. We use 4% on most of our adults. Basically, quick rule of thumb, anybody less than 20 kilos, 1% over 20, 2% over 40, 4%. And keep it about 2 milligrams per kilogram. That keeps it pretty safe. Steroids, 0.2 milligrams per kilogram of ideal body weight. That's everybody that comes in. Single dose of steroids isn't going to send your sugar sky high like everybody thinks. It's, of course, repeated multiple dosing that does that. We have many patients that come in with higher sugars before than after. So inhaled beta-2 agonists with anticholinergics, the earlier the better. If your patient's suspected bronchospasm and you try and give albuterol, it's too late. It's not going to get to where it needs to go. You can't even get oxygen there, much less medicine. So if somebody especially has inhalers at home that they take, we highly recommend giving it to them preoperatively. If they are going to do something, it's not going to be as bad if they've got that beta agonist on board. Anticholinergics as well, keeps them from being too soupy whenever you guys are DLing. And all the other positive things, anticholinergics, especially anything around the neck, is going to prevent as bad of a vagal response. They may still vagal, but it won't be as bad as it would be without the anticholinergic. Adequate hydration, very strict crystalloid. We're not dealing with a lot of third space loss, and to remember that giving these people a whole lot of crystalloids, it's all going to go to the site of trauma, which is the larynx, and that's the last place that we want edema. So very calculated fluid administration. And lastly, humidification of all the gases that we do. Having an HME on everyone, it's pretty hard to catch anything that's moist on fire. So that's one of our fire preventions, but it also helps mobilize secretions and prevent, another way we prevent post-op respiratory complications.
Yeah, and these really are pearls. I don't know how much it's resonating with some of you, but for the people who work in the airway all the time and the anesthesiologists you work with, they should, hopefully they have the same understanding. So.
This is.
Logistics for a second. For the inhaled agents, we did that happen.
For the albuterol, if the patient has their meter dose inhaler, I'll have them hit it before we go back. If they don't have one, we'll try and order an actual nebulizer treatment. That's a little bit longer, a little bit more effective. And then, of course, sometimes while they're going to sleep, we can put it in the mask as well. So whatever you have time for. Nobody wants to sit and wait 10 minutes for a neb to go in. But it is better to get it in as early as soon as we get there. If they have a history of it, if they have their own, have them take it. If not, order one immediately and get it on board. It lasts 4 hours. So the earlier, the better. Continuation of prevention of problems. Everybody likes to give Versed. Nobody wants to remember anything. I don't want to hear anything. I don't want to remember anything. It's a fantastic amnestic, but in our aging, widening population, it's not the best drug of choice for preoperative administration. It's great for amnesia, but it has been shown to cause the most post-op cognitive dysfunction in the elderly, post-op respiratory complications in the obese and in children, as well as emergence delirium in children.
But yeah, we still use it on every single case, right?
That's it's a hard thing to break. Doing patient-specific anesthesia, it's more time-consuming and there's a lot more effort into it, but it pays off in the long run. Pre-medicating with the antisialagogue, we'll do that IV. It doesn't take much, 0.1 to 0.2 milligrams per period of glycopyrrolate. 0.1 is the smallest dose you can give, even to an infant. It's 100 mics. Anything less than that, you can cause a refractory reaction. It'll actually cause some bradycardia, especially in the infant population. With the desflurane, the blue gas, it's the most expensive one, of course, because it works the best. It's on when you want it, it's gone when you don't. And then in the morbidly obese population, especially anyone with a history of BiPAP, I mean, every single night they slap a BiPAP to their nose just to go to sleep. So to think that we can give them a lot of medication and anesthesia and not need a little bit of help when they're waking up is kind of silly. So don't ever be afraid to extubate to a non-invasive form of ventilation, either BiPAP, CPAP, and PACU until they're all the way awake. These people are more sensitive to all of the anesthetics anyway because they're chronically hypercarbic and have respiratory acidosis, which causes all of our medicines to work better for them. They're more sensitive. So early addition of BiPAP in the recovery room, or plan to extubate to BiPAP until they're doing well enough to wean off of that, and your at-risk patient population's important key.
Okay. Thanks, Skylar. There's lots of equipment. This isn't an equipment talk. You got to have your flexible scope. The key things that we really use are a 50 centimeter 0-degree telescope, because this is the best optical stylet that you can get when it's not flexible in terms of your Lewin-Ridge endoscopy and seeing something and measurements, lots of things. The ability to do jet ventilation here, different lasers. Balloon dilators are game changers, right? You have a critical airway and things are going bad, you have that balloon ready and you get that airway very quickly. It may not be how you want to do it in a controlled standard, but it sure is nice to have available. In jet ventilation, it's in the U.S. versus South America versus Europe, it's done very differently. We used to not have the oscillating ventilators, the jet ventilators, high frequency, low frequency jets. We do now. They're available. Most hospitals don't have them. Our European colleagues use them all the time, and certainly some of the centers do. We are typically doing a supraglottic jet. Some people like to use the catheters that used to go below the cords, and the idea of low versus high frequency. We're doing a low frequency supraglottic jet ventilation. And this is our setup right here. You can see the laryngoscope suspended. Here's the jet needle, but this is the end-tidal CO2 monitor. You can get a perfectly acceptable wave to know your level of end tidal with that. Nobody does that, but it's extremely helpful. So we'll pay attention to, as we're rejetting the patient, we've done our 3 minutes of apnea max, and they're hypercarbic to 50 when we start jetting them again, and we're not going to hit them again until we get them back to 30. It may add a little bit of time, but we're getting it may not be as clean as a closed circuit, but it certainly is giving us a nice appreciation of what that is. We spent a bunch of time talking about TIVA, IV induction, the ability to mass ventilate the patient. Every patient's going to sleep this way. And I'm sitting there right at Skylar's shoulder, or one of my team members, with all of our equipment ready to go. And you got the mask? Can you move air or not? At that point. Yes, Karsten.
Just one point. So this is again the elective scenario, which
Yes.
is nicely controlled and pretty straightforward if you've got the right team and the right gear. Don't forget that in an acute setting, the laryngoscope can be your friend for many ways of getting the airway. And the best laryngoscope is actually, for me, in my hands, the anterior commissoscope, the Hollinger anterior commissoscope. It's a unocular scope, but it is the greatest laryngoscope on earth for getting an airway, right? So if the anaesthetist can't see the airway and the situation is emergent, it's basically you can intubate the airway with that laryngoscope, either via retromolar approach or any approach that allows you to get there. And even if you've got a tumour or another type of obstruction, you can almost invaginate the scope in the supraglottis to kind of get to the trachea. And once you see the airway, you just get your anaesthetist to just hold the jet at the opening of the laryngoscope. You don't need any fancy attachments, and just jet. And that buys you so much time to do whatever else you want to do. Once you've established the airway, you can actually use it to put an uncuffed endotracheal tube or a cuffed tracheal tube straight through it and intubate the airway. You've just got to take the connector off and then slide it out, and the airway is established. Or other situation would be just to do a trachea. Somebody can do a trachea below you. Please, question.
What size tube can you get through a Hollinger's?
5. Yeah. I mean, that's a bit of a tight fit, right? But it doesn't matter. The proverbial is hitting the fan. You just want to get a tube in. You just lube it up, and it does slide in. I'm just saying that's one. The other thing is just to use an uncuffed tube that you've got handy, or get the balloon and rip it off and just put it in. I mean, you just want to get oxygen in. Yep.
What about just using a bougie to establish the air?
I hate bougies for the simple reason that you can't control what happens to the tip of the bougie, and you can actually injure the trachea, and bougies fall out, and then the tube doesn't actually, because the tube, when you've got a bougie in and you've got a supraglottic tumour, the tube gets caught at the supraglottic tumour and it doesn't quite go in, and then you use a lot more force. So I think to say that I hate bougies is maybe a bit much. I mean, in certain situations it works very well, but I think if you can see the airway, you can just get a tube and just push it straight in. Anyway, it's just a point that I think truly it is one of the greatest scopes known to man. Unfortunately not known to our anaesthetists, certainly not in Australia. To me, I always say to my residents, if you can't see the airway with that scope, you've got to do a trachea under local.
Yeah. Right tool for the job. This is a CRNA. Here's a hand jet. There's lots of different ways to do it. The TIVA. We tell all of our students that are coming in with Skylar is essentially is 2 ways you're going to hurt these people. This is an elective jet ventilation, as Karsten alluded to. I know that in a lot of hospitals they still aren't doing this. Major hospital systems, because they've had trouble, but they don't communicate and they don't do it well, because we've written up series of many patients in a row with 0 complications from doing this in a coordinated manner. And the way that we hurt people with elective jet ventilation is if you overstack the breaths, you have to allow that expiratory time, and you're blowing the air through a narrowing under high pressure. It takes longer for it to come out. So you have to use at least that 2-to-1 ratio. And then, as Skylar talked about, you've got to have that anesthesia deep enough for the stimulation within the larynx. When you're not giving them gases, you've got to keep that down for them. You don't want them bucking. Skylar?
Yeah, so again, dense paralysis with at least an amnestic dose of total IV anesthesia. We generally keep our propofol no less than 75 mics per kilo per minute to prevent any chance of recall. Excuse me. IE ratio of at least 1 to 2. You can make them longer. just to prevent it from stacking breaths. You want full egress of everything that you put into the chest. So we watch it, and it almost falls in two cycles as it comes down. We keep our delivery pressure less than 28 psi. We never go over it. You'll see stuff that people say you can go over it, but increasing your risk of barotrauma. We have our larger people that don't necessarily jet very well, and then we have our younger people that jet extremely well. And for our studies, we've just maintained 28 psi, 2 atmospheres of pressure, and for someone that's extremely easy to jet, we'll just limit our inspiratory time. Once the chest comes up to an apex, we stop delivering. And we always have a 502 readily available, especially in our obese population. They'll often just slowly fall over time, and you'll never get them back to their starting set. So we'll put a 502 in, recruit the alveoli, really hyperoxygenate them, and that'll give us a longer working time in between. We try not to, but if you can't work because you're jetting for 5 minutes and you still aren't getting the SAT that you need, you have to do something differently. Positive pressure is key in this patient population because they often have restrictive lung disease at baseline on top of undiagnosed obstructive lung disease. So.
Yeah. Getting them back up makes all the difference. Just an article about this idea of doing this that was part of Skylar and some of the rest of the team in heavier people. This is just demonstrating a jet case. I'm going to skip up and just show you here. Let's see. I think we'll see some jetting so you see what that looks like. This is a patient with posterior glottic stenosis. I started too far. There, you can see the jet in terms of what that looks like with the supraglottic jet. Let's move over to airway fires. We're running a little long here. There's about 600 fires a year. Laser is a big part of these. A lot of it's done in airway surgery, and the biggest thing we catch on fire typically is endotracheal tube. All right, fire triangle, we all are familiar with. The other thing that's interesting in this is the role of airflow and the difference that makes. It's kind of like blowing on the coals of a fire. There's something that's not alluded to, and they're starting to look at that a little bit. What in terms of risk of fire with that flow in terms of liters per minute, what that oxygen concentration is, you see how they diverge here as we get higher oxygen concentrations. Key pearl here is, remember, this isn't just about your inspired oxygen, this is your expired oxygen. And your anesthesiologist is monitoring this. But it takes 3 minutes or more typically to get down, this is saying 2 here, to get that expired FiO2 down. So you're ventilating the patient with 100%. That expired gas may be 40, 50, 60% in your expired oxygen concentration versus trying to give a chance to get that down when you're lasering. Prevention and management of operating fires, laser-resistant tubes. Again, we had no disclosures, but we are really excited that Carson and Skylar both seen it. I got to get to the expo today. Brian Medical has a new laser tube that's coming out that is no longer going to be a cheese grater or that soggy noodle that's so giant. So stop by and check it out, or it's supposed to be available in the next few months. Protecting, these are the recommendations of the anesthesiologist, all very obvious. Nitrous oxide also burns. Wait a minute before you do it, as you know. If you have a fire, get it out of there, okay? I mean, the first thing that's happening is, before anybody else knows that that tube should be behind you, out of the airway, okay? Or whatever it may be. Stop all flow, get the airway fire put out. You've got to have that saline available on the table to get that taken care of, and then reestablish the airway. Looking for anything you might have left behind and assess the patient. So laser precautions, you can see in a jet ventilation case here, we actually have the chest out. See how you can see this right here? Our drapes are pulled back. You've got the towels around the head so that we can actually see the jet. Evacuate the air column because char and laser plume can burn. Okay, that's dried carbonaceous debris. Remove those fuel sources. So don't want to spend too much time on that. This is Murray's component. I wish he could be here to do a better job explaining. Carson, you want to tell him about it?
basically the main issue of laser, of a fire, is oxygen, right? With 100% oxygen, as soon as you get into the airway, you basically have a jet of fire getting into the distal airway. If you're running at 30% or an FiO2 of 21, all you do is really just get a smouldering off the tube, right? So O2, oxygen, is the most significant ingredient in causing a fire. So it doesn't matter whether you have laser-safe tubes, whether you have God knows. If you're running at 100%, you're going to have a major risk of a fire. If you're running at 21%, that risk is very, very low. And in fact, you might still get a little local issue, but you're not going to get the catastrophic distal burn. I trained with Wolfgang Steiner 20 years ago. He did over 3,000 or 4,000 laser cases just with normal MLT tubes, right? And that's because he understood how you take care of the airway and don't get a fire. So to me, laser tubes are clearly necessary, but they're a governance issue for our hospitals, that they won't let us laser, etc. But it doesn't stop you having fires either, all right? So the key is oxygen.
We lost our great laser tube that we all loved because of an airway fire. Any tube can catch on fire, and this was their response. The metal tubes can burn like any other tube, right? It's all about the oxygen. Any fire that I've ever had to take care of the patients was always in a situation of increased FiO2.
And what you can see with that metal tube, right? Halfway up the tube, you can see it go red because the fire is still continuing in the tube. See that?
So, and people think the fibers can't burn. Here's a case of a fiber that sparked and nearly caused a fire on an intratracheal tube. Those are laser cases. I'm going to let Karsten give us the details here on the Thrive. Do you want to just go?
So Thrive's a game changer, and I am no expert. It's really our anaesthetic colleagues. They understand all the physiology, so I'm just going to talk about it in very simple terms. Thrive is an acronym, and it stands for Transnasal Humidified Rapid Insufflation Ventilator Exchange. I mean, only an anaesthetist could have come up with that. I mean, it's just bloody ridiculous. Anyway, and the whole concept really is running high flow humidified oxygen through the nose. And I tell you, it has been a massive game changer in what we do. There are so many applications, but we sort of starting to routinely use it for microlaryngoscopy, and for the vast amount of patients, you can run these patients completely without a tube. They maintain their saturations, and it allows you really to do a whole host of both diagnostic and therapeutic procedures short of lasering. The only caveat is that in patients who are overweight, people who have a very crowded oropharynx, it can be a bit of an issue, certainly when the patient's just lying there. Once you put a laryngoscope into the airway, then that collapse is often overcome. But again, if you have an elevated BMI, then you will run into trouble because you just can't, the lungs just, the exchange is just not quite there. So then sometimes we supplement those patients with jet ventilation. Where I think it's been a massive help is in the management of acute airway problems. So in people who, after certain head and neck procedures have run into trouble, people who present with other acute glottic issues, just a sliver of an airway is enough for the oxygen to go down, and it often buys you an incredible amount of time, and it allows you a much more measured, sound and calm approach to securing somebody's airway. So if you guys are not familiar with it, I think it's something really important to speak to your anaesthetists in your local hospitals and potentially start using it in normal microlaryngoscopy cases. The great thing will be when we are developing techniques to use a laser. Clearly, running 100% oxygen through the upper airway is going to be a problem when you're lasering, and is really an absolute no-no. but there are some studies being done to see what happens when we suspend insufflation of the upper airway, and potentially you can do some laser procedures in apnea. But I think it's been a massive game changer, and I'd be interested in your experience, Kyla.
Oh, well, we would love to. We've been trying to get it in our facility, and researching different avenues to just try and get it and try it out. But unfortunately, we haven't been able to get it in our facility just yet.
I mean, it's a very simple device. It's a high flow oxygen delivery system with a humidification. You can often change the FiO2 as well, and it's a very simple device. Nasal prongs. One of the things that does happen in some patients, it can actually precipitate a bit of allergic rhinitis in patients. We've had that occasionally just from the high flow going through the nose, right. But it's otherwise incredibly well tolerated, and it just allows just a real wonderful assessment of the airway. I guess one of the key things is to avoid aspiration in these people, because you do have an unsecured airway, so you've got to make sure that your people are appropriately fasted, and you've recognised people who've had gastric sleeve or various types of hiatus hernia, because that can often lead to a bit of a surprise. But again, once you've got that patient suspended and there is any concern, it's just simple just to put a tube in, and then block the airway off, with the cuff, and then you have a completely safe airway. So I think it is, it's like anything in medicine. It's not something that needs to be done on every case. It's just a wonderful way of, again, delivering personalised care to our patients.
Right. When you hear these guys, the anaesthetists talk about it, they talk about this idea. The ideas of how it happens actually are not completely understood. They even think there's some respiration secondary to the heartbeat in these apneic patients. But for comparison here, so they think it's a washout as well as an elimination of dead space and a little bit of low PEEP. What we're familiar with in the States typically is vapotherm, right? And that's up to 40 liters a minute versus this is 60 or more. Their own literature says they don't know exactly how it is. It's about those things, and they're still working on trying to figure that out. This is a comparison of the PEEP in terms of what happens here with the airflow. Let me just, for the sake of time, let's have.
That's actually that's the video. So this is the exact scenario of a patient. Sorry.
No, please go. Yeah, tell us.
So this is one of my patients. He's got an anterior vocal cord cancer, cancer just below the anterior commissure. So we're running 100% oxygen at 50 litres. You can see that his saturations are well preserved. This is 2 minutes of apnea, no tube in situ. We're basically doing a laryngoscopy. I am not fulcruming on the upper teeth, as I've got my thumb there, just for anybody. I always use gauze, because I think any other mouth guard just steals too much airway, and if you're careful, then you can do it properly. That's a Dido laryngoscope. So again, at 10 minutes, saturations are completely preserved. And this is just being able to allow, and you can see the cancer he had a small cancer, but unfortunately the guy eventually lost his larynx when he failed radiation. Just a cancer right below the anterior commissure there. And, it allows you, again, 25 minutes, again, saturation's preserved. So, plenty of time to do whatever you need to.
When Karsten, I was down in Australia for a meeting, and they were introducing, Fisher had this as the booth at the meeting, and Karsten's like, it's bloody amazing. It's like magic. And that expression I think is really true in terms of the difference maker that this can be. And people are looking at different ways of using this as an application. But after my experience and being friends with Karsten and doing this, I came back and we were called to the emergency room for a patient with an obstructing laryngeal tumor. And it's a big ER, and it's when you open the doors, you can hear the patient. You don't need to ask anybody what room they're in, because they have such loud stridor echoing across the entire ER. And go in and see the patient, massive obstructing supraglottic tumor, and we don't have Thrive, but I said, well, get us some vapotherm. And so we get the vapotherm on at 40 liters a minute, and it's amazing. you can hear the stridor in the room, but you don't hear anything in the ER anymore. And the guy settles down, his tachypnea goes away, his pressures go down, and all of a sudden we've taken somebody who's about to get an urgent, emergent wake tracheostomy, the time to take him upstairs to call the OR, have everything set, take him up there, and resettle down the situation so that before we jump off the cliff, we have time to do what we need to do.
So we do it for all our subglottic patients. It's such a routine now for us, and it's something where I actually have to pinch myself with my anaesthetist because it's so bloody easy, right? The patient goes to sleep, it's ventilated, the Thrive's put on, and then the patient just lies there on 100% oxygen, saturating perfectly, and everyone is telling jokes and, getting the setup. It is so bloody easy, honestly. You just can't believe it. For the difficult airway, I had a patient with a recurrent larynx cancer last year. Basically when I did the laryngoscopy, there was no airway I could see, but he was on Thrive, saturating at 100%. Because there was a tiny little pocket of where I could put the laryngoscope around the tumour and got into the airway. That's all you need. It is quite a phenomenal technique, and I really would encourage people to explore it with their team.
Right, and there's a lot of data coming out on this and a lot of different applications. Of course, I'm going to skip over the laser.
Another one.
You want me to drag across there? Is there anything?
Yeah, look at him yawning away. He's all relaxed.
Yeah, and
again, same scenario. Yeah, don't show this because this is not official yet.
Yes. So
what actually happens, and I'll just say it, when you turn Thrive off, you can see within 30 seconds the FiO2, which we've measured at the glottis, drops below 50%. And that's just without suctioning the oxygen sump. So I think there is a situation which will clearly need to be published and demonstrated where this will be officially safe, but I wouldn't encourage doing that yet.
Yeah. We've got a few last minutes, just a couple of cases here to go through. This is a B-cell lymphoma of the epiglottis. And so, Skylar, what are you thinking about this one?
Well, it's in the epiglottis, so a straight blade, you're going to mash it. So definitely going around with a fiber optic scope and maybe with a molecular scope to lift everything out of the way in combination with fiber optic be the easiest way to move everything out of the way.
Thrive. No, that's no joke. This is the perfect scenario because there's airway behind, so oxygen will get in. And then once you get a scope into the vallecula, like a Lindholm, the whole thing will just lift off. So again, you look at that before the advent of Thrive, and that was a crappy situation, right? That's tracheundolocal almost, because no matter what you do, if you give positive pressure, you cause an airway problem. Putting a fiber optic scope's not that easy either, because that tumor keeps falling in, and in a patient that's not cooperative, it can be a real disaster. So this would have been this is a very, very difficult scenario.
Yeah, he was handled with fiber optic intubation. But
that's
with the drug set ready.
Yeah.
That's
because you're good.
This is a patient with a plasmacytoma of the trachea. So we get all kinds of fun stuff. And you can see, we'll go down and take a look at this thing. It's always impressive to me. This is this idea of chronic versus acute that we started with, right? If this were an acute obstruction, this guy'd be dead on the floor, right? This is a slow-growing tumor that's taken a long time that he's managed to be walking around with this and probably treated for asthma, with it. And so what are your guys' thoughts on how to manage that one?
Well, when we intubated.
No, we didn't intubate this one. No, if you intubate, you would shear it off.
There's no way we intubated that one. So, and then mask ventilation, it's obviously ball valving. PEEP during mask ventilation, it's going to be the only way we can stent the trachea open to get to that.
Any thoughts, Carsten?
Yeah, I think, again, one of these complete nightmare scenarios, because I think you've got a very high risk of causing a major issue. but it's a bit like the scenario of a peanut, in the trachea. You're going to have to breathe these people down and then have a good inspection of what's going on. I mean, the fact that the guy walks around or the person walks around is reassuring, but if you're trying to do something that's not controlled by direct vision, you're going to run into trouble. So I think once you sort of see that and the person's breathing spontaneously,
Right.
you can potentially pass a tube just past it,
Yeah.
a small little tube, and then you get to assess exactly what's going on and then, knock it out. I mean, even doing a trachea under local is going to be really difficult because you're going to be straight onto it, and you can be a bit shocked that you're not actually getting the airway that you thought would be pretty straightforward. So I think this is really difficult. I mean, that's like the peanut in the middle of the trachea. I mean,
Right.
that's, and this is even the sort of scenario where it might shear off, where you actually put it down one side and ventilate on one side, and then control yourself. Get your control back in your own mind, and pull it out.
And these are the kind of cases that you face, and it's all about this coordination and having a good pre-op exam ahead of time and making a plan. And like Carson said, some of these tumors that we get in the trachea, you can slide a tube around because you've got the give posteriorly. It depends upon the tumor, and I think imaging in these cases is very helpful because is there dense tumor around the trachea? Is this extrinsic that's compressing it as well? And that may not be as giving in a firm tumor versus if this is a more endobronchial and endotracheal lesion, there may be a little bit more give in the trachea in terms of the flexibility of that to get by. And that can be helpful. I'll tell you that this guy actually did get a mediastinal trach where we went, and dove deep to get around this thing because I was worried about it based on his habitus. He was a really big guy, heavy set, and I was worried about doing it. Very similar cases, we've done exactly what Carson says, where we slip a small tube around. The idea of also working unibronchially is very helpful at times.
that case. So because he was so heavy set, getting the supraglottic jet, that wasn't an option.
I was worried about it in him based on body habitus. He was a big, heavy-set guy. It was amazing he was walking around with that. And that's actually the lowest trach I've ever done. I did it with one of my senior head neck partners, and we did it in the cardiac suite. Some of these tracheal kind of tumors, we have thoracics on standby that put these people on pump. We're going to look and see, and they're gowned and gloved and ready to go.
Wire in the groin.
Yeah,
Guide wires.
or guide wire in the groin on these really bad ones. Absolutely. Just big.
Again, it's not the sort of case where you would CT this person knowing that the problem's there. I mean, the reason why that person had a CT is because somebody couldn't really work out why the hell he was short of breath and you couldn't see it from the top. And because, he was walking around and clinically there wasn't an issue, they put him through the CT scanner, I presume.
Yeah.
And then incidentally somebody went, oops, look at that. And because, doing a trach, not knowing where that is, I'm not sure you'd know exactly where to go in. But if you know it on a CT scan, you can count the rings down, and then when you get down there, you can kind of pull it up like you're doing a cricrotracheal resection. So again, it's personalised care, isn't it? And you've got to have a good team, and that's the reality.
And having that evaluation and working together and having a plan. And we had a bunch of plans. We were ready to intubate if we needed to. We had cardiac surgery available. We did a lot of different things. Large just ball valving mucoid mucocele here, not so tough. Let's see here if we can skip over. Pretty straightforward for what we see every day. Like a fixed laryngeal web in somebody that we're going to jet ventilate. And, they're walking around, they may have stridor, it may be too small to intubate, but you can feel very confident about your ability to get around something like that with laser. And one last one I'll show you.
I mean, that airway is plenty, right?
Yeah.
So when you see that, that's not an issue.
Right. Supraglottic stenosis can also be a real challenge in these cases. And you think, I can see the cords. When you go to intubate these people, when the larynx is locked into the tongue and the hyoid, the larynx doesn't present itself on direct laryngoscopy the way you think it's going to. And it can be a different angle to turn that corner, much more so than you think. And just a word of caution on those as well. So, but that's...
I think that's a really important point. One thing I always say, there's two types of direct laryngoscopy, right? There's diagnostic laryngoscopy and there is therapeutic laryngoscopy, right? And each type requires a different endoscope, right? The concept, or a different laryngoscope. The concept that we were taught as residents 20 years ago, that get the largest laryngoscope, shove it in and go for it, is absolutely erroneous. You know, often the smallest laryngoscope, like the anterior commissure is a great laryngoscope to do a diagnostic laryngoscopy, right? But then to work with something, you need to have a working or a therapeutic laryngoscope. And to really understand the difference in what you're trying to achieve is really important. And a scope like, that sort of case, exactly like Andy says, it's actually really difficult to see the larynx. And in that scenario, you might need a Lindholm that sits higher, that kind of exposes that area. Because if you're using a normal laryngoscope, you're not going to see that airway.
So thank you for your time.
Thank you.